Well, in this presentation we want to look at some of the management principles that apply in acute kidney injury, formerly called acute renal failure. Now, before we get down to specific aspects of management, I'd like to think about some of the general principles involved in caring for a patient with acute kidney injury. And the first one's fairly obvious. It's to prevent the condition if possible, and if we can't prevent it, it's to correct it as quickly as possible by correcting the underlying cause. So, for example, if the acute kidney injury is caused by an acute hypovolemia, we'll want to give intravenous fluids up until the point where the patient is euvolemic. Hopefully this will mean that because there's now adequate blood volumes, the kidney will be adequately perfused and renal function will be restored because we've corrected the underlying cause. Of course, that means we have to identify the underlying cause before we can correct it. Then we want to keep the patient alive until spontaneous recovery occurs. Now, this is an acute condition and we're hoping for a recovery. Now, it's true that acute renal failure can become chronic kidney disease, but the vast majority of cases we're hoping to restore renal function. So it's a matter of maintaining the health and well-being of the patient until the kidneys resolve and start working again spontaneously, as they should do in the majority of cases. So observations of fluid status are clearly pivotal to our management of a patient with acute kidney injury. We want to know how much fluid is going in and how much fluid is coming out. And think about the fluids in food as well as fairly obvious fluid like water and cups of tea. And then we want to see how much fluid is coming out as well. So this can be fairly obvious that we can measure urine volumes, but we also need to consider loss through diarrhea, through excessive sweating, through vomiting and other causes of fluid loss, so we have an overall accurate fluid balance. Now, monitoring fluid status allows us to follow the evolution of the condition. So if urine volumes are continuing to go down, it may be that the acute kidney injury is becoming more severe. So it will allow us to chart the condition. Or if urine volumes are starting to go up, it may be that the condition is starting to resolve. So we can monitor the progress of the condition. And we should always use fluid balance charts. But sometimes this can be difficult, so there's an additional strategy that can help us. Now, if you don't eat for 24 hours, you're probably going to use 250, at most 300 grams of fat. So you're not going to lose a lot of weight by not eating for 24 hours. So if a patient weighs 2 or 3 kilograms less today than they did yesterday, that's because they have lost water. Sudden changes in weight are due to fluid balance. So if a patient is losing fluid, they can be developing a negative fluid balance. But in acute kidney injury, if someone's not producing urine, they're likely to go into a positive fluid balance. So if someone weighs 3 kilograms more today than they did yesterday, that's because they're accumulating fluid, the water. And we can work this out very simply because 1 litre of water weighs 1 kilogram. Now, in established renal failure, the patient will be on fluid restrictions because we don't want to cause fluid overload. And the mouth gets very dry and crusted. And drinking is a very psychological phenomenon as well, so the patients will often feel quite thirsty. So if we look after their mouths and keep their mouths clean, they'll be generally more comfortable. And as well as that, the mouth is a possible source of infective complications. So we want to keep the mouth fairly clean for microbiological reasons as well. And chest physiotherapy is also important because chest infections can complicate virtually any condition actually. So we want to keep the patient as active as possible, keep them in an upright position for at least quite a lot of the day to encourage expectoration of sputum. And we want to encourage them to cough up and expectorate sputum, so we keep the mucociliary clearance system going to prevent possible chest infections. Because if pneumonia sets in, if there's infection at the level of the alveoli, then that is clearly a life-threatening condition, and it's much better to prevent it than treat it should it occur. Now, in the past we might have put these patients on bed rest and catheterised them. Well, we don't want the patients to be on bed rest, because if a patient's on bed rest, they're at risk of the complications of immobility. So we want these patients mobilised within the limits of their condition on that particular day. So promote mobility as far as is feasible for the individual patient. And if we've got a catheter in, it's very useful because we can do hourly volumes of urine. And that lets us chart fluid balance charts very accurately, and it looks nice and tidy. But of course, catheters have a great risk of infection. And these patients are at risk of infection already, and we don't want to increase it because of our iatrogenic catheterization. So avoid urinary catheters if at all possible. Only catheterize if you have a very good indication so to catheterize. Now, if you were to eat 2 large bananas, which is quite feasible, it would be good for you. They're very high in potassium, and you would be consuming about 1 gram of potassium. That's fine because your kidneys will just excrete the extra potassium, because it's the kidneys that are homeostatically regulating the amount of potassium in the blood. But of course, if you've got acute kidney injury and you've got a renal failure, then you're not going to be able to homeostatically regulate your potassium. And particularly, you're not going to be able to excrete potassium. Now, the amount of potassium in the blood is not great, but it has to be accurately controlled, because potassium is an electrolyte. You can see here it's a K+. It is a positive ion, and it's vital in the maintenance of the physiology of excitable cells. And excitable cells are the nerve cells and the muscle cells. And of course, when we're thinking about muscle cells, we must think about the myocytes in the myocardium, because the myocardium is a muscle. And it is essential that we have the right amounts of potassium in the blood and extracellular fluids to maintain the right electrochemical balance across the cell membranes in all excitable cells, but in particular in the myocardium. So it's very important to have the right amounts of potassium in the blood. So if we're working in a situation where blood biochemistry is readily available, we need to monitor the patient's plasma levels of potassium very carefully. But if we're in a situation where such biochemistry is not readily available to us, we need to assume that the patient's potassium is going to go up or is at risk of going up. So we don't want to feed them foods that contain potassium. So potassium is in fruit juices, lots of vegetables. It's in fried food and crisps, and there's some in tea and coffee as well. So we don't want the patient to be eating a lot of potassium in their diet because they can't excrete the potassium because they have a renal failure, because they have an acute kidney injury. And if we give these patients lots of potassium to eat, so if we fed them bananas and fruit juices and vegetables and chips and crisps, then we would put their potassium up. Their serum potassium would rise, but their kidneys cannot excrete it in the urine. Therefore, they would become acutely hyperkalemic. Their potassiums would rise, and this is a potential life-threatening situation. So if a patient has an acute renal failure and you give them high potassium foods to eat, then that can kill your patient. Now, the levels of serum potassium will normally be homeostatically regulated in the range 3.5 to 5 millimoles per litre, sometimes called milliequivalents. Some labs may give slightly different reference ranges to this, but it's all in this area. Because as we've said, there's not a lot of potassium in the blood really, compared to sodium, for example, which is 135 to 145 millimoles per litre. but it's absolutely vital because of the effect it has on the electrolytes and the electrochemical balance that generates the potential difference across the cell membranes, particularly of the myocytes. So a lot of people will say that a hyperkalemia begins at 5.5 or anything above 5.5 millimoles per litre of serum potassium, and anything above 6 millimoles of serum potassium per litre of blood is considered hazardous. And what we're particularly concerned about is the effect on the heart. So we want to monitor the ECG or EKG. We want to monitor the electrocardiogram. So we get a rhythm. We can see what rhythm the patient is in, and we can also observe, as we'll see shortly, the shape of the complexes. Now, if we're acutely worried about someone going into ventricular fibrillation in hyperkalemia, we can give intravenous calcium gluconate to stabilise the myocardium. Of course, we'd want these patients to be monitored and we want intravenous access, but we can protect the myocardium. So, for example, 10 mils of 10% calcium gluconate given intravenously, but give it slowly because, of course, it's calcium, it contains calcium, which is in itself an electrolyte. So it must be given slowly. And this will stabilise the myocardium, but only for a period of time. And another emergency measure is salbutamol. Now, probably need a 10 to 20 milligram dose of this via a nebulizer. Salbutamol, you might remember, as a beta-2 agonist, and it will lower potassium levels. It stimulates the sympathetic nervous system, but it does lower potassium levels. And the literature informs us that salbutamol can lower potassium levels by 1 millimole per litre in about 30 minutes. But it will only maintain it for about 2 hours. So these are both really emergency measures if we're very worried about an acute hyperkalemia. Now, if we've got a bit more time, then we can give ion exchange resins. For example, calcium resonium. These are given orally and will attract potassium into the ion exchange resin, so the potassium will be excreted via the gastrointestinal tract. But the standard way of treating acute hyperkalemia is to give glucose and insulin together. Now, there are different protocols for this, but the essence of it is that we give insulin. Now, when insulin facilitates the transport of glucose into the cells, the potassium will also move from the extracellular fluid into the cytosol in the intracellular fluid with the glucose. So giving insulin is going to lower serum potassium levels because the potassium is going to be gated from the extracellular fluid into the intracellular fluid. So once the potassium is safely inside the cells, it's not going to be causing a hyperkalemia. But of course, when we give insulin, that's going to dramatically lower the blood sugar levels. So we give this with glucose to prevent the hypoglycemic effects of the insulin. High potassium levels can also be reduced by dialysis or hemofiltration. Now, if you're looking at a lot of medical textbooks, it will give you some clinical features of hyperkalemia. But in poorly patients especially, these can be missed. So actually, one of the main clinical features of hyperkalemia is that there are no real specific clinical features. This is something we need to suspect. We need to monitor the blood levels primarily, rather than going on the clinical picture. But perhaps the exception to that is the monitoring of the electrocardiogram, because there will be changes. So, for example, if the serum potassium is in the range 5.5 to 6.5 millimoles or milliequivalents, we get a peaked T wave. The T wave becomes pointed with a shortened QT interval, the interval between the Q and the T. So remember the P QRS complex and the T wave. and the ST segment can be a little bit depressed as well. But the thing that we tend to notice primarily is the peaked T waves, and as we see, that's quite obvious on V2 and V3. But if the serum potassium continues to rise, say in the range 6.5 to 8, those peak T waves are going to persist. But then there's going to be decreased or disappearing P waves and a widening of the QRS complex. And hopefully you've identified the hyperkalemia and treated it by the time it gets to this stage, or indeed before. But if not, and the serum potassium goes above 8, then the P waves are likely to disappear altogether. There's progressive widening of the QRS complex. There's various types of heart block, and the patient is at risk of ventricular fibrillation and asystole. So this is a life-threatening condition. But if we are monitoring the ECG, hopefully we can catch it at a much earlier stage. Now, of course, physiologically, homeostatically, the kidneys are controlling the amount of water in the body. But in acute kidney injury, this isn't going to happen. So when the patient is euvolemic, we want to give the previous day's losses plus 500 mils of water per day. Now, acute kidney injury, of course, can be caused by dehydration and hypovolemia. So if the patient was hypovolemic and anureic, we'd want to give fluids to perfuse the kidney. But we only want to give fluids in an established case of acute kidney injury until the patient is euvolemic. So euvolemic means the volume of the blood is correct and contains the right amount of fluid. Not enough would be hypovolemia. Too much would be fluid overload. And we don't want any of those. So what we're saying is, as a rule of thumb, as a principle to guide our management, is that if there's established renal failure, established acute kidney injury, in a patient that's euvolemic, if we give too many fluids, will cause fluid overload and all the problems that go with that. So we need to monitor the previous day's output. What has the patient lost in urine, in vomit, in stools, whatever it is. And to that, we want to add 500 mils for the insensible loss. So if the patient has a fever, they might need a bit more than that. If it's a very hot climate you're working in, they might need a bit more than that. But we normally say 500 mils for the previous day's insensible loss. So that means is we're putting in or putting back, giving back the fluids that the patient lost the previous day, plus the 500 mils for insensible loss. Therefore, we hope we're maintaining euvolemia, but we're not giving additional fluids, which will cause fluid overload, and we're not giving insufficient amounts of fluid, which can lead to a progressive hypovolemia. Now, of course, that's only our starting point, but it's a good starting point. 500 mils a day of water, plus the previous day's losses, as a general principle. Now, we've already discussed the importance of not giving oral potassium in acute kidney injury, but it's also the kidney which excretes increased amounts of sodium in the plasma. So if we give the patient a lot of salt in the diet, that's going to tend to make the patient hypernatremic, which we don't want. So as well as being on a low potassium diet, these patients should be on a low sodium diet. We shouldn't be giving them salt and salty foods. Now, if someone's vomiting or has diarrhea, they're going to be losing fluids, but also electrolytes. So sodium and potassium can be lost in vomit and diarrhea, as well as the fluid. And we need to account for this in our management of our patients in acute kidney injury. And ideally, we want regular biochemical assessment of the blood to look at the electrolyte levels. So if the patient is becoming low in potassium or low in sodium, we can compensate appropriately. Now, there's an interesting discussion to be had around the aspect of feeding patients with acute kidney injury protein. Now in health, remember you only need about 0.8 grams of protein per kilogram of body weight per day. But in illness, you may well need more protein than this. For example, if you have infection, you're going to need additional proteins to make antibodies. So what's the thinking about restricting protein in acute kidney injury? Well, if we give patients too much protein to eat, then that will be metabolized by the cells, and particularly in the liver, there'll be a process called deamination, where the amino acids in the protein are broken down to give energy yielding food type products. But proteins contain carbon, hydrogen, oxygen and nitrogen. So if someone has large amounts of protein in the diet, they're going to produce more nitrogen. That's going to go into the blood and form ammonia, NH3. But as that goes through the liver's going to convert it into urea, which of course is normally excreted by the kidney. But in acute kidney injury, because there's renal dysfunction, because there's not adequate normal renal function, then the urea won't be excreted and the patient can become uremic as the levels of urea in the blood rise. So the idea is that if we feed these patients a lot of protein, more nitrogen will be produced and that will accelerate the development of uremia. But we have to bear in mind that poorly patients also need protein. So again, it's sort of a general principle, a rule of thumb that we might want to restrict patients' protein to about 40 grams a day, unless there was a particular indication to increase the amount of protein we were giving our patients. But we want to give plenty of carbohydrates to prevent protein metabolism. Because in the body all the time, in your body now, of course, you have huge reserves of protein in your muscles. And if you're not eating, then there will be catabolism of those muscles. Those muscles will be broken down to release energy, to give energy providing food molecules. And if we don't give adequate carbohydrates, the amount of sugar in the blood will drop. That will lower the amount of insulin, and there can be breakdown of skeletal muscles to provide energy. And of course, as those skeletal muscles are broken down, then the nitrogen is going to be released into the blood, and that too will contribute towards the development of uremia. So we can prevent catabolism of the patient's own protein reserves by giving adequate amounts of carbohydrate. So if the amounts of carbohydrate are high, the amount of carbohydrate in the blood is going to stimulate insulin levels, and insulin actually stimulates synthesis of protein, if anything, but it will prevent the breakdown of protein. It will prevent protein catabolism. That's good because we can preserve the musculature of the body and the body proteins. But it's also good in the short term because the nitrogen won't be increased, contributing towards the uremia. Now, regardless of the cause of acute kidney injury, the condition will be exacerbated by infection, especially if there's sepsis. So we need to carry on our routine clinical observations, observing for the presence of sepsis, and if it's there, treating it appropriately. And that will treat the sepsis and also improve the prognosis of the acute kidney injury. Now, we're hoping that the episode of acute kidney injury is going to be a self-limiting problem. So this means that urine production should start to recover as the acute kidney injury recovers. And hopefully we'll get sensible volumes of urine being produced. But it's quite possible that when urine output does recover, there's going to be a diuretic phase, and large volumes of dilute urine can be produced really quite rapidly. And the problem with this is not so much that the patient will become hypovolemic, although we do need to monitor their fluid status, but it's more that there'll be an electrolyte imbalance, as the patient can potentially suddenly excrete a lot of sodium and a lot of potassium. And rapid changes in the levels of electrolytes, particularly potassium, can be dangerous. So if the potassium's dropping quickly after having been high for a period of time, that's a potential risk. So we need to monitor the fluid and electrolytes very carefully if there's a diuretic phase. possibly giving replacement therapy as indicated. Now, we can give patients renal replacement therapy while we are waiting for spontaneous renal function to recover, and this will maintain the patient's fluid and electrolyte homeostasis and control their waste products, facilitate elimination of waste products, and generally, as it says, replace renal function for a period of time. Now, peritoneal dialysis is a lot better than nothing, but it's not as effective as hemodialysis at all. We used to use peritoneal dialysis quite a lot when hemodialysis was less available. But the great thing about peritoneal dialysis is, although it's less effective than hemodialysis, it's very low tech. It's relatively straightforward to perform, and it's also relatively cheap to perform. So it's worth considering if you're in a situation where hemodialysis or ultrafiltration might not be readily available. But intermittent hemodialysis is remarkably effective, and intermittent or continuous ultrafiltration can also maintain renal function for quite long periods of time until the patient's renal function spontaneously recovers. Now, thinking about acute kidney injury caused for pre-renal reasons, so pre-renal acute kidney injury, the most common cause here is low blood volumes, hypovolemia. So the essence of treatment is to give fluid replacement therapy. Intravenous fluids will be given until the point that the patient is euvolemic. Euvolemic means they have normal blood volumes and normal proportions of fluid in the blood. So we want to give fluids, but we want to avoid fluid overload, especially if there's reduced renal function and they can't excrete the fluids that we're giving them. And ideally, we could monitor central venous pressure levels via an invasive line and titrate our fluid replacement according to that. But if that's not available, clinically there's quite a few things we can do to observe for the possibility of fluid overload. And one is raised jugular venous pressure, congestion of the jugular veins, as the blood can't get back into the right atrium of the heart. And a classic feature of fluid overload is pulmonary edema, and very often the first thing we notice there is orthopnea. Now, orthopnea means the patient finds it difficult to breathe when they're lying flat, but when we sit them up or lean them forward, they can breathe more easily as the fluid settles down to the lower parts of the lung and leaves the upper part of the lung free for gaseous exchange. And with pulmonary edema, the patient will develop basal crackles as well that we can learn to listen for. And as well as pulmonary edema, over time there's going to be the development of peripheral systemic edema as well, which would all be signs of fluid overload. Now, postrenal AKI is caused by obstruction of the flow of urine after it's left the renal medulla, typically after it's entered the bladder and can't get out via the urethra. So ultrasound is very useful for diagnosis here, but so are our clinical skills. So we need to find out if the urine is being retained in the bladder. So we can palpate the pelvis, we can percuss the pelvis to see if there's retention of urine. And we need to ensure free flow of urine, that is the management of postrenal acute kidney injury, to remove the cause. And this is one of the situations where we may need to catheterize the patient, hopefully just for a short period of time, but it may be necessary in order to ensure that the urine is being appropriately voided from the body.